shoulder pathologies are the fastly evolving science in arthroscopy. The conclusions which were there in 2010 are not there in 2020. And now what we'll discuss in the next 5 years will not be true in next coming 10 years. So there is no black and white. I always operate or I always conserve. There is a science behind it. So these are the groups of patients we have seen in our routine OPDs. So they come with different age group. There is different history. Some are traumatic, some are non-traumatic. There is different clinical presentation. Some have pain and some may have weakness or night pain. And then there are more confusing MRI images. Some show partial cuff tear, some show retracted tear. And these terms like it's a high-grade tear, but it's a partial thickness tear. So it's a little more confusing. There are distances of retraction, and then some confounding factors like labral tear or Hill-Sachs defect in presence of a rotator cuff tear. So these are different confusing terminologies. And there is always a defensive golden line by a radiologist that please correlate clinically. So ball is in our court. So there is a saying, a good surgeon doesn't just concentrate on technical ability, but also on the appropriateness of what you are doing. So there should be some reason why you are operating. Let us start with the first case. She is a 54-year-old housewife, asthmatic, on steroids since last 2 years. She had severe shoulder pain since last 6 months, unable to sleep at night. Clinical examination again shows restricted weakness of forward flexion and restricted rotations. And here is her MRI showing interstitial tear. Somebody said, please go and operate. And patient was admitted for the same. Now, few points to remember. This is a non-traumatic tear. Associated comorbidities like diabetes, use of steroids, and in these cases, successful rehabilitation program always work because the confounding factors here are diabetes and osteopenia. If you treat these two enemies, she will have a good outcome. So she is after 6 months with full range of motion, but still in evolving to regain her power in the rotator cuff. Similar example, pain in shoulder, typical diabetic female, restricted range of motion, abduction. Again, anterior superior tear was a MRI finding. She was advised surgery. Another patient, 55-year female, HbA1c was 9.2. Again, to point to note, these are non-traumatic tears presented with stiffness and weakness, combination of the two. So here again, there is a partial articular side tear, pasta tear, somebody advised the surgery. So these are the typical patients, they have very high chance of responding to the conservative line of management. So these patients underwent physiotherapy, lot of steroid intra-articular injections. Some may have to undergo manipulation under anesthesia and home-made physiotherapy program. So partial thickness, basic anatomy, they are bursal-sided or articular-sided and less than or more than 50% of the footprint. If you see the anatomy, it's a huge attachment. 17 millimeter of rotator cuff is attached on the greater tuberosity. So 5-7 millimeter of tear should not hamper the clinical activity. So overall, these are middle-aged, in Indian scenario, these are middle-aged females, diabetic, with some are weekend warriors who recently have higher levels of lipids in their blood, and they go on gymming at weekends. So these people also get partial tears, and all these deserve conservative trial as a modality of treatment like activity modifications, stretching exercises, and anti-inflammatory medications. So age-wise, partial cuff tear in young is a different scenario. They usually are traumatic, and in athletic patients, if rotator cuff is the primary pathology, they will definitely need surgery. But in Indian scenario, 70 to 80% partial tears are chronic, non-traumatic. They are comorbid like diabetes, minimal physical demands are there. They are happy with their homely activities. So a lot of them respond to conservative therapy. Now, if conservative treatment fails, we may, if the tear is more than 50% of the footprint, then we can go ahead with the complete takedown of the tear But again, these are very high tension repairs. On the contrary, patient may have increase in the pain instead of the pain getting reduced. Now, progression to full thickness varies from 8 to 53%. There is very strong association between symptoms of recurrence of symptoms and tear size. Now, again, Sharmaji told this A.J. Ito is a Japanese surgeon who is a pioneer in the shoulder surgery. He conducted a trial of 102 shoulders in 100 patients undergoing a conservative therapy for a period of 32 months. And surprisingly, the success rate was 75%. And these were for both partial and complete tears. So who will respond? The patient who have impingement sign, there is maintained active external rotation and lesser fatty atrophy. These people will respond to conservative therapy. Now full thickness tear, here is an example. A 65-year-old lady had a shoulder dislocation at home with a trivial trauma. We did MRI and CT scans. And then there are no lesions, but there was a rotator cuff tear. And she is here after a conservative line of treatment. She has adequate power of abduction, external rotation, maybe grade 4, but she can manage her daily activities. Another example, 54-year-old laborer lifted a heavy bucket. She had pain and slight weakness. If you see the MRI, there is around 2 centimeters of retraction of the tendon tear, good muscle belly, and type 2 acromion. He again, if you see the range of motion, he is able to carry his daily activities with adequate amount of abduction and external rotation. Some pain management is always required. I'll just move fast. So full thickness tears are classified depending upon the amount of retraction, the area of involvement, superior, posterior, or anterior, and the amount of fatty degeneration. These are the 3 factors where we can decide whether patient should go ahead with a conservative or operative. All elderly will put full thickness tear, they need conservative. There is a right that they should undergo conservative treatment. Now, what is the literature? There is a meta-analysis which shows there is no clinical difference between surgery and the conservative at 1 year follow-up. Again, second meta-analysis shows constant Morley score of at end of 12 months is 77 in operative and 72 in non-operative. So there are higher surgical failure rates in older patient, massive tears, and with tear retraction more than 22.5 centimeter and fatty degeneration. So you have to be very cautious while treating these patients. Massive tears, so more than 2 tendons with gotelier wasting 3 to grade 3 and grade 4. So what is the option? Reverse shoulder, which at least costs 4 to 5 lakhs. The balloon itself costs is 3 lakhs. And tendon transfer, these are morbid procedures. You are taking one tendon, one ligament from the leg and tying up. Still you are not sure you will get adequate amount of result or not. And here is a concept of copers and non-copers. These 2 ladies have similar amount of retracted tear, and one had active abduction, one could not do the active abduction. Why? Failure to heal structurally doesn't necessarily lead to frank clinical failure, which means you should understand the basic biomechanics. The role of rotator cuff is to compress the humeral head against the glenoid, and then only your deltoid will act. If there is a tear in this anterior and posterior the pillars, then only they will have weakness. If the tear is in the crescent area, the yellow area, still we can get away with adequate amount of conservative therapy. If there is uncoupling of the essential forces anteriorly of subscap and posteriorly of teres minor, then only they will have weakness, anterior superior escape. So this lady who is not able to do abduction, she had the unbalancing of the curved forces, and the lady on the red side who is able to do active abduction, she has maintained the balancing forces. I can treat conservative. If I say that I must have a very good physiotherapy protocol, then here is a standardized rehabilitation protocol which says that non-operative treatment gives equal results to the operative therapy. And what do? They correct the uncontrolled movement of the humeral head and doesn't allow them from escaping anterior superiorly. Also to note down is the scapular dyskinesia. If you treat the scapular dyskinesia and scapular stiffness, many of them respond very gracefully. So strengthening of the anterior deltoid is one of the exercises which prevents the anterior superior escape and still manage to increase the abduction movement. Also exercise in elevated position negates the effect of torn rotator cuff. What is the protocol? Structural home exercise program, improving the passive forward flexion, external rotation, deltoid and teres minor strengthening, adequate amount of subacromial steroid injection, maybe 2 or 3, postural or scapular stabilization, NSAIDs, and proprioceptive exercises. Predictive of conservative therapy success is intact subscap and teres minor hypertrophy, and patient should be willing to undergo the exhaustive physiotherapy protocols. So isolated subscap tear rule is type 2 tear, 70% will go and respond to conservative therapy. Type 3 and 4, they will have to go surgical line of management. Again, not to forget is Parsonage Turner, which always presents like a pain and weakness of the shoulder. It is post-viral brachial neuritis, similar presentation of rotator cuff tear. So proper clinical examination will isolate this condition. So in conclusion, failure to heal structurally doesn't necessarily lead to clinical failure. So if you find the tear, don't hurry and jump on to repair the tear. Thorough clinical examination, good protocol of conservative treatment, activity modification can save patients from costly surgeries. Almost 75% patients of rotator cuff tear in Indian scenario can undergo conservative treatment and respond. So rule is patient should demand the surgery and not surgeon to sell the surgery. Thank you.